Ready? Okay, go live. Go live. Okay. Okay. Hi, everybody. Good afternoon. We just can't get LinkedIn on. Afternoon. My name is Justin Blake, and I've got my good friend and colleague here with us today, Simon Costain. Simon's in lovely sunny London this morning in Harley Street. Simon, how are you?
I'm good. Fine, thanks. Good.
How's things been in these strange times?
Very odd. We've been working through most of it. We've been
strange times. Yes. And yes, because you had just a small sort of hiatus, didn't you, from the from work?
Me.
Yes.
Yeah, no, we worked through most of it. We've took a couple of weeks off, but then we had quite a few patients who needed some help. So we carried on working through. And some of those patients were diabetics and others were athletes and dancers and so on who have problems and need to continue with their job, really. So that's why we carried on.
Yeah, it's been. I think it's been a very good time for people to start to. Let me just see this. Start to really get on top of injuries that have been niggling for a long time. Talking with Tom Novella, I mean, he was working with a couple of his ballerinas, and there was one. He reckons she'll have extended her career by another 8-10 years because she was really able to stop dancing, let the injury settle, and then do a lot of rehabilitation. So I think it's been a great opportunity for a lot of people to really get on top of a lot of long-term. And as you know, working with athletes and with high-level people across the years, I mean, the main thing is getting them to stop doing stuff, to allow things to settle, decrease the load.
True.
Yeah.
Well, we look after quite a few of the London dance companies, and one of the challenges for them is to maintain their fitness, of course, in their little flats and so on, because they face challenges of how do they keep fit in their flats and their bed sits. So it's a challenging time for them. But yeah, as you say, it's a time when they can actually come to grips with problems, try to identify the cause of the injuries and try to resolve it. But challenging times for the dancing crowd.
Yeah, I know a lot of the ballet dancers. I mean, there's been a lot of stuff on social media, a lot of Zoom classes for ballet and for right across the board. I mean, I think this is a fantastic time to be in healthcare. I mean, a really fantastic opportunity now because everybody's mind is so much more focused on fitness and health and vitality. I mean, if you look out the window here, I mean, everybody's out cycling and running and walking, and I play a lot of tennis, and it's great to be in the healthcare business at the moment because this is a golden opportunity, a really golden opportunity to increase the profile right across the board. And so, Simon, I mean, you've been involved in Harley Street. I mean, I think nearly 40 years now.
Oh, over that, since 1985. I first moved in.
And Harley Street would have changed quite a bit since then.
Oh yes, it has. No, it has. I mean, when I first moved in, there were only 2 podiatrists in Harley Street, and now there's quite a few.
Yes.
But we've been there ever since. Well over 40 years now. And
what was what? I mean, did you because why Harley Street?
Well, I was working in Northampton for quite a few years.
Yeah.
And then I worked with David Bell in Maidenhead when I was doing foot and ankle foot surgery.
He was one of the leading foot surgeons, wasn't he?
He was, yeah. He was the chairman of the Podiatry Association at the time, and he and I ran a practice in Maidenhead.
Yeah.
And then I ran my own practice in Northampton, and I got quite hooked on non-invasive solutions for foot and leg problems.
Because you gave up the podiatric surgery to focus on the muscular. You gave up the podiatric surgery side to focus on the musculoskeletal thing.
Yeah, I have to say I got a bit bored of doing foot surgery, to be honest, because it was quite limiting, really, to just toe straightening, lumps and bumps. And, you know, I found more with the surgery we did, the less we were thinking function. So really, so in my view, it's always been to try to identify the mechanism of injury and resolve it non-surgically. And I think we share.
Yeah, I did my first. I did my first surgery exam back in '93 or '94, I think, with Ron McCulloch. I think Ron's gone on to do more.
I know Ron well.
Ron and together, and I just didn't really, it was, I prefer the musculoskeletal. I prefer the fancy surgery.
I mean, I think the big divide for me was when I realized that I was concentrating on just the foot with surgery, whereas with musculoskeletal work, you think whole body, really. And I think that divides the surgeons from the musculoskeletal specialists. We do think, we have to think more holistically, musculoskeletal world, whereas when you're focusing on just a procedure surgically, then I'm afraid that's what you concentrate on. So it's what you become very good at.
Well, of course, a lot of the podiatrists. Sorry about that. A lot of the podiatrists have, of course, a good biomechanics background as well. Yeah. So hopefully they're taking that into consideration when they're performing certain procedures. And so then so after Northampton, then off down to the bright lights, big city in London.
Yeah, no, I was invited down by one of the dance companies to come and see some of the dancers down there. Yeah. Then I was invited in to work at a place called the Harley Street Sports Clinic with the late John Davis, Professor John Davis, who was a sports medicine doctor, Malcolm Reed and Mike Hudson. They were running a show there, a clinic there. And I was brought in as the podiatrist to them. And then in '92, I left there to go and be the podiatrist to the Great Britain Olympic team in Barcelona.
That's right, Barcelona. That must have been fantastic. I mean, was that the first time Harry got involved in the Olympic program?
Well, I was with them a little bit before that, leading up to the Olympics. So I worked at the pre-Olympic selection process work at the various centres throughout the country, 4 different places. But I'm concentrating mainly on leading up to Barcelona. So that was an exciting time to go and do that. And at the time, I was the only podiatrist actually at the Olympics with the medical team. There were quite a few some physios there, but there were no other podiatrists. So it was quite a hard work, actually.
Yeah, you must have been busy. I mean, I think at the last Olympics there was 14 or 20 of a team.
Well,
in London. And yes, and of course, well, everybody wants to work with high-end athletes, but as you and I know, it can be quite a challenging experience at times, because not only are you working with the athlete, you're working with the coaches and you're working with the management company, and I mean, there's a whole sort of series of people you have to go through even before you get to put your hand on the athlete.
Yeah, true. And I mean, the athlete can be high-end, or he can just be somebody who likes to walk his dog around Regent's Park, actually. Yeah. It's the same problem. The only challenge is that the athlete tends to earn their living doing what they're doing. And so obviously with that little extra pressure means we have to try to come up with solutions as quickly as possible, which I think is why sometimes the athletes choose the more radical approaches, the surgical approaches, which hopes to give them a real silver bullet. But as we all know, it's not always going to do that.
No, I mean, you often hear, I mean, on a Sunday afternoon or a Monday morning, you hear that the latest rugby player is off to go under the knife. Such and such a sports person. I mean, I know my colleague Nick Cullen in Stanmore, the orthopedic surgeon. I mean, he told one of the English rugby girls a couple of weeks ago. Apparently, I would never be able to do this. I never jumped in the line out enough. She jumped in the line out in a practice and came down and crushed her talus, and he had to pin it. I mean, no sort of,
horrid,
and so. But I think, I say, hopefully now, anybody who had a long-standing niggling injury, who was, as you and I know, working with these athletes at this level, everybody's always carrying some niggle or some twinge, and never 100%. So hopefully this is the time that we will be able to really have rehabbed this property and extend their career. Sorry if there's a bit of noise. The guys have decided to dig up the street while we're on the call outside. They're putting in some new paving and things. But
No, I mean, when we started work in '85, there were really only one or two people interested in sports medicine. There was the JPR Williams, the John Williams from Wexham Park Hospital, Barbara Ansell we worked with, and really there were only one or two orthopedic surgeons who at the time were specializing in feet, because feet were at the lower end of the.
I've got an interesting Harley Street story about one of those guys who were leading light in the apparently when he with his Rolls Royce, because he liked to have a drink in the evenings, he would dress as the chauffeur and put his wife in the back and drive home from the roller from Harley Street in the uniform, so he wouldn't get stopped by the police. I can tell you who that was later on. A leading light in Stanmore, the godfather of foot and ankle surgery. You know who I'm talking about.
I do. I do.
And that's quite an interesting story. But I mean, that was old Harley Street. Now it has changed. It's very much more commercialized.
No, it is. It has changed a lot.
And I mean, sports medicine has really taken off. I mean, and I mean, of course, the technology that they're using now with the stat sports tracking and all the sort of prehab and rehab and everything. Let me just close this window a second till these guys are getting very noisy. Hopefully that will be a little bit better. Sorry about that. So yes, I mean, now the athletes are well, of course, sometimes it's difficult to know where to start. I mean, I know where to start, but I mean, they're getting looked after so much more, and I mean, of course, they're competing at such a higher level now as well.
I think the diagnostics have improved exponentially over the years, so that really we can now see things, see pathology much more easily. We can actually identify where the problem is using a number of different scanning systems, CT, MRI, ultrasound, and now we can identify the pathology. And actually the dynamic assessment of the way that feet, legs, backs work has always fascinated me. And it was my cousin who, I'll tell you this story, you've told me one, I'll tell you another story. He came in to watch me working on an athlete, and he happens to be a racehorse vet. And said, he said he watched me treat an athlete with an Achilles tendon problem, and then and a plantar fasciitis pain. And then after the patient left, he said to me, "I'm really glad to see medicine at last catching up with veterinary." He said, "You're only about 50 years behind, but there again," he said, "your client's not very valuable."
No.
So you're about to be 50 years behind. And he said, in racehorses, we use exactly the systems that you use of adjusting the way in which the foot of the horse works to optimize their function. And he said, it's really simple. It's driven commercially. You take a £10,000 racehorse and take a proper farrier, and the farrier will put proper racehorse orthotics on the shoes, and the horse will become a £100,000 racehorse. So he said, it's simple. He said, you've not got that yet with humans, but it may happen eventually. And so and he gave me a book called No Foot, No Horse. And that was one of the reasons whenever I gave lectures to any group of medics or non-medics, and they asked for reference books. I gave them the reference book of the equine vets, which is no foot, no horse, because it explains everything that we do, but in equine terms. And it's been around for years. So nothing new, really.
No, as you say, commercially driven. Yes, the studs, the Coolmore studs, the Al Maktoums in Dubai. I mean, the whole racehorse industry is multi-billion-dollar. Ireland's very. I have a friend now who is working with a lot of the racehorses, putting the stat sports chip, so they'll be able to actually. The stat sports that all the footballers and all the American football, they're putting those in racehorses now, so they'll be able to see the acceleration, the stride length, the cadence, and they'll be able to do the variables with those. That's my good friend David Gregory in Ireland is working with that. Interesting times ahead, and as you say, the imaging is especially now with the group practices, and of course where you are. I mean, somebody just pops up the road, they have the scan in 2 minutes, they're back down with you, they know exactly what it is, and then you can do the program there. And that's the great thing about working in that sort of environment.
Yeah, it is. No, we're very fortunate that way. We don't have to wait for long if we want bloods run or we want some other pathology tests run or imaging. We can usually do it on the day, which is quite useful in London.
Yes, and of course, I mean, in your practice, I mean, you have X-ray on site and video analysis and an F-scan and shoe pressure as well with the other guys you work with, because it's not just you alone. I mean, there's other
about 5 of us all together. That's right. Yeah. Denzel Trabilko works with us. You know Denzel.
Yeah, I know Denzel. Yeah.
A lot of work with the Royal Ballet Company. He does a lot of work with pressure analysis. His background is as a physicist as well as a podiatrist, so he's very experienced and very good with patients. And then we work with two other podiatrists, one other osteopath, and a physiotherapist who concentrates on foot and ankle physiotherapy.
Yeah, because I mean, when I had a talk with my colleague Pat Ruddy, who was the lead dancer with the River Dance on Broadway for 3 years, and the Irish dancing. Yes, I mean, it only struck me when I was talking to him, the Irish dancers who are competing in the World Championships at 8 and 10 and 12 years of age. I mean, they're elite athletes at that age.
Yeah.
It's I mean the training that goes in, the competitiveness. I mean, it's absolutely phenomenal. They are world-class athletes at 8 years of age.
No, the dancers are very, 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 very high-class athletes and very highly tuned.
Yes, very dedicated. Yes, all the ballet companies were all training at home, all having Zoom calls. A lot of there was a lot of on social media. A lot of the prima ballerinas, especially New York City Ballet. I can't remember her name, and she was on Instagram every day doing a live class. The ballet companies had sent them all out special cushion mats to dance on.
Yes,
The companies were
ballet and contemporary dance. We see quite a few contemporary dancers too. So of course the distinction there is the contemporary dancers are barefooted, so a little different, to treat them a little differently to the ballet dancers who wear their point shoes for the girls and the dance shoes for the boys.
Yeah, the interesting thing with of course with any dancers is always that we're very limited with the footwear of getting anything inside to help. So it does tend to be a lot more on the strength and the control around the core and and around the glutes and things, and further out. So then so no surgery, MSK Barcelona, and then on to, well, of course you've lectured as well.
Many years.
And how do you think the future? Do you think the future is bright for podiatry? I mean, I think there's a little bit of, well, see, I don't understand, of course. I mean, you probably don't spend any time looking at any of these, but there's a lot of Facebook groups and a lot of podiatrists on different chat rooms. And I mean, I don't know, they're all worried about their practices and worried about things. I mean, you and I, when we worked in London, we never had an issue with fees, Simon, and we never had an issue how to charge properly. People are concerned now. Of course, there's the triple lock of people don't want to come out. You have to spend more time with patients because of the PPE and social distancing and all those sort of things. But people are very reticent about putting up prices and charging a fair fee. That's never been an issue in Harley Street, has it?
Well, no. I mean, we in Harley Street, we, like anywhere else, we have to charge a fee that represents the amount of costs to run the practice, and renting buildings, running the service charges, paying staff, London waiting and so on is always more expensive than it was in Northampton. So obviously the fee structure has to reflect that. Yes. You know, we also have concentrated as well on being a specialist podiatry unit in London, concentrating mainly on the non-surgical work, which has involved us in a lot of investments on equipment, which had we run a standard podiatry practice, we wouldn't have had to invest in. And that equipment has to be replaced, and so inevitably, the costs have to be higher.
Yes, but I mean this has been the constant thing that I've been talking about on our business evening chats and all the CPD that we've been doing, which has been fantastic for everybody over the lockdown period. You know, you have to charge just slightly more because ethically you need to, because you needed to invest in yourself and then invest in your practice and your family, so you can then take more care of patients better. I mean, it's a no-brainer, but I don't understand where colleagues, I just don't think they value themselves enough.
No, I think that, you know, well, one of my colleagues is an orthopedic surgeon, and he is a very good foot and ankle orthopedic surgeon. And his approach with patients who challenge him on his fee structure is quite simple. He said, look, I do charge more for what I do, but then I do a lot of it and I'm hoping I'm good. I can find you someone cheaper if you wish.
Yes.
It's up to you. And his view has always been, well, I'm happy to concentrate on the area I'm good at. If someone goes to see him about a knee problem, he'll refer them to someone else because he thinks it's much better to go and see someone who's good at knees. He said, although I could do a knee, I wouldn't do it as well as my colleague. So he said,
you and I have both had hips replaced. I think you've had both done. I've had one.
Yeah. Very good.
Absolutely fantastic.
Very good hip replacements. Highly recommend them.
Most highly recommend them. Tennis, back sailing. It's fantastic.
I mean, if you have that, you know it, don't you?
Yeah, and sailing then, of course, when we both sail, we both sailed a bit.
Yeah, we are.
You've done a little bit more now. I think we're going to sail together next year if we for this forgottenfeet.org. We're going to sail. If anybody doesn't know, forgottenfeet.org is a UK charity. Looks after homeless and vulnerable people, provide great podiatric care from a lot of clinics. And next year, they're doing a fundraising. They're going to cycle from Land's End to John O'Groats, 900 miles in 9 days. Okay, Simon and I realized that it's probably easier to sail with a fair wind. We will be there in 4 or 5 days. So we're in the process of getting sponsorship, and that should be awesome. And there's a lot of interest from the from colleagues both here in the UK and Ireland, and also overseas as well. So hopefully, with COVID being over, I think it's May the 7th next year. We're going to be casting on. It should be good.
Yeah. No, sailing. I've done a lot of sailing over the years. I've done some dinghy sailing, got a lot of dinghy sailing. Started off sailing enterprises, and then I went to 505s, and then I sailed a laser SB3, which has now become an SB20 sports boat.
You were first in the class around the island race.
Around the island, yes. SB3.
How long was that taking an SB?
Now, probably about 7 hours, I think. Okay. But then I started to get interested in inshore racing.
I prefer bigger boats.
And bigger boats as crew. And then I decided I'd like to do all my qualifications to become a skipper. And in 1985, I'd completed my Yachtmaster Ocean commercial ticket. So then I took a trip across the Atlantic with an old sailing mate of mine called Tom Cunliffe, who writes a lot in magazines.
World.
Tom's a good long-term friend of mine, and he wanted to help from the Caribbean in his gaff cutter called Herta. So we sailed back from Antigua, well, from Anguilla, in fact, after we'd sailed around the Caribbean for 2 or 3 months. And it was quite a pivotal point for me in my career, because I decided I was going to either continue with surgery or do something different. And it was that trip that made me decide I wanted to leave surgery, having done 12 years of it, really.
Okay.
And I wanted to move into the musculoskeletal field. Okay. So I was offered a job in Bermuda in the sports work, but didn't take that one up.
Then a couple of. It's a fantastic place. The sailing's phenomenal. I have a colleague, Philip Mann, who spent about 8 years out there. Philip's now in the south of Spain. He loved Bermuda. Yeah, it's absolutely fantastic, absolutely glorious weather, and the sailing's superb. Yeah, and my colleague Sean McCarter, who I sailed one of the clipper legs with, he's just actually had to come. He just had to come back from Antigua, had to sail back, and he ended up sailing back with his 6-month-old son. They couldn't get any flight to get him and his wife back, so they sailed back to Palma. Sean and his wife, funny enough, Sean's wife can get me on a J class.
Oh yes, how lovely!
So there's a couple down in Mallorca at the moment, so we may pop down in a couple of weeks. Even just to get to walk on one would be phenomenal. But of course, I'll be trying to get a sail on it as well.
Yeah, wonderful experience. And I've sailed across the Atlantic and back 3 or 4 times now, and I've enjoyed every time I've done it. And I've been sailing all sorts of boats. I think my this next boat that I'll have is probably my 11th or 12th boat that I've had. So the last one I had was a Class 40 race boat, and then the previous one to that was an X50 sailing Danish-built boat. Lovely boat.
One of the across the Atlantics was in a classic boat, wasn't it?
Yes, it was in a boat called Chloe May, which was a Percy Dalton designed gaff cutter. She was 40 feet long. Lovely, good fun. We had a wood-burning stove on that boat. Great fun. Not that we needed it in the Caribbean.
Atlantic for the Caribbean, no. Well, maybe chilly evenings, perhaps.
Yeah.
Although today's great and the summer weather's really picked up. And I mean, I think you saw my sailing video from the weekend. I was out sailing, didn't have enough wind.
Yes, I saw that, yeah.
We had a bit of good fun in the 15. Yeah, flying 15s are really good fun. We have good fleet here in Carlingford in the east coast in Laos.
Yeah, fantastic.
In Dublin, we've got a fleet of about sort of 10 or 12.
Yeah.
Maybe get 8 or 10 out on a weekend. I think we're going out tomorrow evening. The tides are right. Yep. Tides are right tomorrow evening. So
that's great.
And they're really good fun, especially when you get a bit of a blow. And of course, there's lots of kids sailing going on at the moment, and things that say that the weather's now picked up, and next year, Forgotten Fleet should be fantastic. We'll bring you to Cardiff. It's although I haven't done much on the west coast of Scotland, so I wouldn't mind stopping off there.
Sure.
Got to give the cyclists a chance to catch up, of course. And then one of them didn't realize. He was like, "What are you going to do with the boat in Scotland?" And I was like, "Well, of course we can't just pack it up through to the car. We're going to sail it back down again." So
absolutely.
I think a couple are quite keen to cycle up and then sail back.
Yeah,
that could be quite a good. Quite a good. So if anybody wants to know anything more about that, you can find details at forgottenfeet.org. or contact me on the usual channels. The future's bright for, is the future bright for podiatry? I think a lot of the SADI are struggling maybe a little bit to attract and keep or retain the students.
Yeah, I mean, it seems like there's a talk within the profession that there's going to be difficult times ahead to recruiting people to do podiatry. But as you and I know, there's an awful lot of work in looking after the mobility of humans, really, and podiatry forms a very, very pivotal role. I think with any profession, if you concentrate on one area of it, become good at it, then there's always be a job for you.
I mean, I think the thing is as well, I mean, I've had 4 or 5 careers within the podiatry career that I've had.
Yeah.
As well. I mean, podiatry is fantastic for that. It gives so much opportunities to do, whether you want to work high-end athletes or musculoskeletal surgery, pediatrics, diabetic foot care, routine. I mean, there's a whole sort of series of within podiatry that you can specialize in. So that's just great. I think certainly compared to a lot of some other professions that are out there. Of course, it's what you make of it.
It is what you make of it, and I think that if you concentrate just on treating the foot without respecting the fact that the foot relates so much to other areas of the body, like knees, hips, and backs, I would say that very few of the patients who are referred to us now are actually referred specifically for foot problems. A lot of patients are referred to us for hip pain or knee pain. Trochanteric bursitis being a very, very big area of work we do now. So pain on the outside of the hips, knee pain, leg pain, back pain, ankle pain. And the foot is a delight.
There's a song goes, Simon.
Yeah.
You know, and I mean, certainly fully integrated body biomechanics. That's where it's at.
Well, it's, you know, you cannot. When I've taught biomechanics, the work we do in gait analysis, I've taught at the London Hospital Medical School for quite a long while with the doctors there, and most of their comments are the same. They say, "Gosh, if only we were taught functional anatomy like this, we would understand how the body works. We would understand that a foot problem can create a knee problem." But of course, we know medicine still, in some respects, is in the dark ages when it comes to identifying the pathomechanics surrounding knee pain, and they forget that a left sore knee can be created by a malfunctioning right foot or a left foot.
But I mean, as we said, we both had hip surgeries or hip replacements. I mean, that's just started off as a misalignment and faulty mechanics repetitively over 30, 40 years that has just worn out the joint. I mean, that's all the osteoarthritic problems are misalignment. If you haven't had a trauma or injury to it, it's all related to your biomechanics. You know, and I mean, I remember Ray Anthony one time telling us about, you know, he luckily saw a girl about 2 days before she was due for bilateral femoral derotation surgery. At about age of 14, some nutcase was going to cut her femurs and derotate them. Ray put her in. Do you remember those little Cobra? What's the name of those little Cobra jelly pink things that he used to sell? I used to use those all the time. Anyway, Ray put this girl in, got a phone call the next day to say the bloody pain had disappeared within 24, 48 hours, and she'd cancelled the surgery. You know, something as simple as a rear foot post had saved that lady from going under the knife. You know, I mean,
we've had similar examples.
The younger surgeons now, especially shoulder guys, foot and ankle guys, I mean, they don't want to do surgery now unless they absolutely have to. They don't know. Yeah, and it's Matt, our colleague Matt Shanahan in Back to Horses and Humans. Matt's done one of the leading courses in Australia in terms of putting shoes on horses. I mean, it was very interesting because he was talking about, of course, that when the hoof hits the ground, it needs to be able to spread, and the shoe restricts that. And of course, I think that's one of your famous quotes before in terms of restriction of feet. You call that shoes leather coffins.
Absolutely. Yeah, because I mean, you know, one of the main causes of foot injury, foot problems, is foot weakness.
Yes.
The hand is so similar to the foot anatomically that a lot of medics are taught the anatomy of the hand, and then they're just given a list of different foot bone names, and told them to learn them. So, and we know, the foot works very differently to the hand, but it is confined in a leather coffin, and as such, it atrophies. So a lot of the foot problems we see are caused by weakness within the foot, as well as malfunction of the structure. So, as you and I know, we've worked many years on functional mobilization therapy to try to move feet around a bit more.
Yes.
And when you move them, they work.
Yeah. Get them moving. Yeah. It's a use it or lose it thing, Simon, of course. And certainly you and I have both specialized over the last number of years in more manual therapies, which has given absolutely fantastic results. Fantastic.
Right. Yeah. What we're doing is we're taking a structure that hasn't been moving for a while and trying to move it, and trying to encourage people to use it like it was probably designed in the first place a few thousand years ago.
Yes. And of course, like a lot of my colleagues who are watching this evening in different places, of course, it just doesn't all relate to men's shoes. Women's shoes are can be quite detrimental. Look great, don't really help a lot of body mechanics, but they used to spend a lot of time trying to help people to be able to wear the shoes that they love to wear.
Well, as you and I know well, some of the worst shoes for feet are actually not the heeled shoes. The worst shoes for the feet are the ballerinas. The very bad shoes. And you and I know, and we understand why that is. But still, the medical field all around us start telling patients who have foot pain to put their flat shoes on. And guess what? The pain gets worse. And you and I understand why that is. And slowly it infiltrates through that actually we need to be telling patients to wear small heels. Create different postural alignment within the body and also the function of the feet, leg, and back.
Yes, a half an inch is okay.
Helps 3/4 of an inch and a quarter. Not 6 inches all the time, but the worst
getting above 3 or 4 inches, it can be a little bit of a problem. But we know how the ladies love their shoes. I've got some colleagues in Dubai and Hong Kong who are watching now who yes, if we had to restrict their footwear, there would be a revolution. So it's
I think every lady knows that a certain shoe goes with a certain outfit.
Yes.
And they've got to wear a certain type of shoe with a certain outfit. Now, most of the time, they'll be wearing those shoes for a limited period. They won't be wearing them all day. So most ladies would wear a 3/4 of an inch and a quarter heel for the day. But if they want to go out in the evening for a nice 3-inch heel to the opera house, then why not? They're not going to kill themselves in 2 or 3 hours. They're not doing much in that time. But what they will do is they will problems mechanically if they wear their ballerinas to the opera house.
Yes, well, especially if they're on point for 6, 8, 10 hours a day. It's
point is a different ballgame. But I always say the only time that mother was wrong was when she told you you've got foot problems, so therefore take those heels off and put flat shoes on. That's my view. Is that that's the only time she was ever wrong. She should. Well,
what about don't wear ankle boots? You'll get weak ankles.
Well, exactly, another one, you see. And yet I have a view that actually if someone were to wear a stiletto shoe, you can only wear a stiletto shoe if your ankles are quite strong. Otherwise, you fall over and sprain all the time.
You'll be spraining. And of course, yes. Well, of course, I think that I don't know whether you saw our talk with Bob Kidd about talus structure and alignment, and a recurring theme. Yeah, ankle sprains are, I think, are one of the most detrimental, have a long-term sequelae of effects on the foot bump. That whole talus ankle complex. Astragalus, the center of the universe. We've got to get it properly. That really, just a very inconspicuous ankle sprain in a teenage years or something like that can have a whole knock-on effect further on down. It's an frustrated chick friends is being used to call me teapot. posture shit. Sorry, just getting a couple of questions in from and online. Sorry about that. And yes, it has a whole knock-on effect. And I mean, I think it's very, very undertreated. I think we undertreat patients a lot in clinics. I don't know what that is, whether that's the sort of the basic training is to get us up to speed to work in an NHS environment where, you know, yeah, I think.
Well, Wes, I mean, the main difference, Justin, between how we work nowadays and how we were probably taught to work is, and a lot of people are still taught to work, is wait for something to go wrong and then try to put it right.
Yeah.
Whereas a lot of the time we work on preventative, prophylactic work. Yes. So, you know, when someone has a sore or something on the foot, we treat it. But then our duty as podiatrists, and I think it is for the rest of the medical field, is to make people aware that mechanically, with that particular problem that brought you to us is only the tip of the iceberg, and we need to treat the mechanism which created it. Because if you don't treat the mechanism, it will create other problems as well.
Yes.
So that's changed a lot over the years. We used to wait for something to go wrong, put it right, and then people came back when it went wrong again.
Yeah, I mean, that's the great thing about working with as you say, dance groups and companies and ballet companies and sports teams, is you're there and prehabilitation, prehab now for
well, I think so. Irrespective of who we treat, it's the same for anyone, even if it's dear old Mrs. Smith who walks down the road with her little poodle.
Yeah.
You know, if she keeps coming back just for the problem for which she came in the first place, and we don't alert herself to the fact that she's walking with a leg length difference or a knee problem or hip problem or back problem, or we only treat the foot problem, we're just treating the tip of the iceberg. So it doesn't have to be the elite athlete. It can be an everyday person, really. Yeah.
It's everybody who wants to keep active and mobile. That's what people do. Keep active and mobile, keep their independence and their mobility, their ability to keep up with their friends, to take part in, you know, in the community that they want to do. I mean, most people don't come. Of course, most people don't come with a. Well, they come with a pain problem, but of course, it's what it's restricting them from doing. You know, they're worried about active, mobile. They're worried about surgery. They're worried about they're going to lose independence and mobility. All those things are affected.
One of the things I've got on my wall of my surgery is something that draws everyone's attention is the Ministry of Silly Walks. Yeah. So John Cleese is a patient, has been a patient for a few years.
Yes.
He very kindly, when he came in for treatment for a knee problem, I asked him how he was getting on about a year and a half into treatment. And he said, well, I think this answers the question. And he threw me a great big poster down, which is the Ministry of
Silly Walks. Yeah. Yes, because you have a who's who around your clinic.
He said, give me your felt tip. Give me a felt tip pen. And he signed it from the Ministry of Increasingly Perfect Walks. And he said, that answers it. He said, now that I'm walking better, my knee is better. So, you know, there's that's always makes me smile, because it makes you realize that actually patients fully understand there's a connection between bad walking and other problems outside the foot, knee, hip, back.
Yeah. I mean, I certainly think that, I mean, of course, with all the sports shops doing a lot of sort of foot things and in shoes and video analysis, I mean, people are getting more,
they're more aware of it, aren't they, really?
More aware of it. Yes, but I'd say your clinic is like a who's who of from sports stars to opera stars to royalty to film and television. I mean, it's quite an eclectic mix.
Well, we've been there a long, long time, and we do see a lot of different people, true, and no, we do, and we're very grateful to those people to come in.
Yes, but and of course you have a lot of with Harley Street as well. You have a lot of Middle Eastern clients from the UAE.
Yeah, we do sometimes,
especially this time of year when we're getting away from the heat of the summer.
Yes, but obviously it comes with different challenges because they tend to wear sandals a lot of the time.
Yes.
So, I mean, every group of people is a little different, but at the end of the day, the problem's the same, no matter who they belong to, really.
Yeah, that was the point of Tom Novella, whether it's a prima ballerina, or as you say, the lady who wants to walk around, wants to walk up the street and just with the dog for a couple of minutes a day. The same thing applies to everyone.
It makes no difference. No, I mean, if someone's in pain, they walk badly. And sometimes if they walk badly, they cause pain. So it doesn't matter who they are. It just happens to be we see quite a few people there because of where we're based. But it would be exactly the same methods of treatment whether I worked in Northampton, whether I worked in London, really.
Yeah, beats feet around the world.
Yeah,
that's what I've found.
Profession, I think it's I think there's great hope for the profession itself. But as you know as well as I, you get as much out of something as you put into it. So if you put a huge amount of effort into your profession, you get a lot out of it.
Okay.
I think that's the tip to most of the junior podiatrists I see, is just put lots of effort in, and you will really reap the rewards. You'll enjoy it.
But also, I think you should do, which I didn't do when I worked in London, which is come along and see somebody like yourself. I mean, we all don't bite. I mean, I did shadow with a couple of other colleagues before, and I mean, I've been lucky enough in Ireland to be part of the university placement student program, and getting those students early. But everybody won't bite. I think that's the main thing. Is just pick up the phone, drop an email to people. Everybody are quite happy to share their knowledge, your experience, and
well, we're always happy. We have a lot of podiatrists sitting in, and we have a lot sitting in who actually want to help us out. So and they want to come and sit and watch what we do. We're very, very welcoming to those people who do. We have not just podiatrists, a lot of physiotherapists, osteopaths, doctors, consultant orthopedic surgeons come in who specialize in feet and ankles. We work very closely with them. And I hold them in very high esteem now. When I first started, there were only 2 known foot and ankle surgeons. And now we have a huge number of foot and ankle surgeons, orthopedic surgeons, who are very good.
And who was that at the time? Was that John Angel was my lecturer?
Well, we probably had Basil Halal, probably even before.
Well, we talked about him earlier.
And of course, the chap who's still around is Mr. Lloyd Williams.
Yes.
Lloyd Williams, very good. So there's a lot of good foot and ankle orthopedic surgeons. They've realized that there's a lot of work in the foot. And they've now become very, very good at foot and ankle surgery, the orthopedic surgeons. Whereas in the past, a lot of orthopedic surgeons tended to delegate the footwork to their juniors. So they've realized now
added on to the end of the list, and got up. Well, not a botched job, but certainly with the leading surgeons like Simon Moyes, like Nick Cullen, like all those other guys there. Yes, I mean those are the guys that are top of their field. Of course, the really interesting thing in orthopedics that we're going to speak with Nick about in a week or two is the whole biologics and stem cells and 3D printing bones and
I think that's all going to
120, Simon.
Yeah, I mean, I'm involved with some MDT, so we're multidisciplinary team clinics where there's usually 7 or 8 orthopedic surgeons who specialize in feet and ankles. There's a load of physios. There's myself with 1 or 2 other podiatrists and osteopaths, and we see 1 or 2 patients with all of us there. And no, I mean the whole world of 3D printing, the stem cell regeneration, the articular cartilage regeneration techniques are all coming along. But at the end of the day, we still all want to, if we can, keep patients away from surgery, no matter what surgery it is, really.
Well, that's it. I mean, as we talked about, it's all mechanically related and a component in it. So if we can catch things early enough, and again do a full integrated between the orthopods and the rehab therapists and the podiatrists and the physios as well, and really focus on the root cause of the problem, as you say, rather than just patching it up until pushing the next issue somewhere else. And of course, that used to happen a lot of times with orthotics, and when we're all putting orthotics in, it was blocking function. Was it giving problems later on? Perhaps it was.
Well, I still believe very wholeheartedly in the use of orthotics. I think they're fantastic tools. I use a lot of them and find them very, very good. But, you know, like anything in life, there's good, bad, and indifferent ones. And, you know, we as podiatrists who use them a lot, have to be selective about what is best for the individual patient. So
yes.
I think that all
you have an in-house lab that you can fine tune to, and I mean that's a fantastic to be able to have. I had that when I was in Covent Garden as well. Yeah, yeah. You know, nothing more than be able just to adjust rather than having to wait for the lab. So you can find
adjustments, don't they? So
yeah,
I mean that's one thing people have to realise is that the orthotic, when you issue the orthotic, is not the final product. You have to adjust it and readjust it and readjust it.
Yeah.
Till eventually,
that was always my question too when I met with colleagues. Sometimes who'd done the weekend courses in biomechanics and orthotics.
Yeah.
My question always was, just how many do you have to adjust? And you know, one guy told me in 6 years, we'll hear this, not one had come back. I was like, really? I've been doing this for 20, 30 years, and I have to adjust maybe one in every 6 pairs, little tweaks.
More than that.
I mean, this guy was like, oh, I know. You know what that means? Patients never bloody came back. They went somewhere else to get it fixed.
Yeah.
You and I, just a very small little adjustment can make a huge difference. But fine tuning,
90% need adjustment really for me.
Yeah. It's a little tweak here and there. I mean, I can't wait. Next year, I hope to go and do some ski alignment and ski orthotics and do that all in Val d'Isere with my colleague Bernard. Well, that would be fantastic to be able to make our footbed and let people ski and come back and adjust and ski it again. I mean, that'll be that. I mean, that's, you know, I wanted to do that for a long time. Just be active on the side of the slope will be good.
Sure.
Yeah. Best lecture. Sean Savage says hello.
Oh, hello.
Oh, Sean, how's things? We were on a talk with Sean last night about student placements between University of Ulster and the Galway University. So that was interesting. Yeah. So Sean says you saw you lecture on dancers years ago. Best lecture he's ever seen, apparently. You never seen me lecture, Sean, then, have you? Because I'm going to be doing some lecturing. I'm going to be running some courses. Well, when we can put people in a room. But I had planned for London 2nd, 3rd of October, and then Dublin, and then Valencia or Barcelona. But we'll see. That's still in the pipeline. We're probably going to do it e-learning is the new way to go. We're working on that because practically putting 20 or so people in a room might be a little bit difficult in October. Well, we'll see. It's still developing, isn't it?
Yeah, sure.
I mean, it's certainly interesting time, Simon.
Yeah, no, very interesting. It's quite nice when it all gets back to whatever the normal is, won't it?
Yeah, the new business as unusual, I think, is what's going to be happening.
Yeah,
it's just continually evolving every day. But I had a really good time over the initial lockdown. I mean, it was a really good time to just take a little bit of a breath and a pause and to reconnect with friends and just reevaluate a little bit as well. There's plenty of time for that. And of course, it was good for me because I was able to rehab my hip more. Hence, we're back in tennis without any issues.
Sure.
London, Harley Street. Yeah, I mean, but London's, of course, is always busy. There'll not be a real downturn in London. But of course, again, that relates back to colleagues who are worried about charging enough fees and charging things. Yeah, I think when you and I missed that class at school where you can't charge a fair fee for a fair days. I mean, when you think of the difference that you make in somebody's life, in somebody's career, in somebody's day-to-day walking around and mobility and things, I mean, it's priceless. And certainly dental colleagues and orthopedic colleagues and other colleagues do not have an issue with fees. I still don't understand. I mean, with the guys that we trained, again, back to Ray Anthony, I think he was said, as soon as you become your patient's bank manager, worry about what they can afford, and then you're really going to be compromising your treatment. So
yeah,
I think
we all have to. I think we all have to look after patients who can't afford some things at times, and we're all tuned into that. And if someone says, "Look, I really like this treatment, but I can't afford it," then we all of us try our best to help that patient out of the problem in a cheaper way if we possibly can.
yes,
but we don't know, do we? Sometimes we have to hope that the treatment that we offer them works, and as such, running a little pilot study with a temporary orthotic or some temporary mobilization to see if we're improving things is something we're all used to doing. So it's all a case of trying to keep the channels of conversation going between the patient and us, and providing we can provide the results for them and they can see there's some improvement, they're happy to invest in it. So
yes. People want the outcome. Again, I think a lot of colleagues focus on the certificates on the wall and the machinery that goes bing in the corner and flashy lights. Patients don't really care about. Patients really don't care about that. They want the outcome. They want to be able to go. They want to be able to go to their daughter's wedding, dance the night away in their Jimmy Choos. That's what they're there for. They want to get back to the high level. They're not there because of your certificate. They're there because you're the leading expert who can help them on their journey.
Yeah, I think what they want to see, to be frank, is that you're putting your maximum amount of effort in. And I think if you can do your best and you can do no more, then that's all you can do. What you can't do is ever guarantee a result. None of us can do that. So, we can only ever do our best. And if we do our best and it helps people, then, it's a fantastically satisfying profession, really.
Yes. And it's, do the best. I mean, we did do some pro bono work for certain groups. But I do find that, I mean, we've always found that, the person who's price shopping you. I got myself in trouble a few weeks ago with my language. The person who's price shopping you, who's I can get it $5 down the road. Well, you can mate. Off you go. As you say, here's a list of alternatives which are cheaper. Nobody wants to be cheap.
That's fine.
I didn't do a deal with my orthopedic surgeon on my hip replacement.
No.
Well, I didn't even ask him the price. I didn't care. He was the leading guy. I got recommended. He was going to fix my life. Well, I was lucky I had health insurance to pay. For it. But I mean, of course, we were lucky with that in London, that a lot of patients are supported by health insurance, which of course then can be very restricting as well, because the health insurance companies don't want to pay out, do they?
No, and so health insurance cover doesn't usually cover most of the podiatry work we do. So patients have to accept that they will have to pay a proportion of it. Some obtain some reimbursements, but most of the health insurance companies only pay a small proportion. So a lot of patients have to pay for it themselves, and I mean they find that's useful sometimes, but
yes, I've got a lot of colleagues in London and also in the States again that we're talking with, a lot of podiatry colleagues, and yes, they want to get out of network. They want to transition to more cash pay plans for their practices, and we've managed to help a couple of practices in the UK and in the States do that, because yes, if the I know my colleague Wayne Edwards there in Aldwych on Harley Street as well. He was telling me about Nuffield now. I mean, you'll send in your plan for the patient, you want to see them 8 times, and Nuffield will say, no, you can only see them 3. I mean, and then don't want to pay and take months. So they've been able to transition away from maybe a 55% reliance on health insurance down now to about a 15 or 20%, and we've helped them do that quite successfully. It doesn't mean you have to see less patients or work harder. Just means you get get a proper fee. So insurance companies, and that will continue to happen as well now with insurance companies. So yeah, anybody wants to know how to transition, from network to more cash pay clinics, then let us know. We can help you with that, because yeah, I mean, I understand the cost of healthcare go up quite a bit, but again, are they really aware of that full integrated mechanical intervention now can stop a problem from 5, 10, 15 years needing a more complex procedures? I mean, I think they're looking very short term, aren't they?
Yeah, I think so. No, I think, at the end of the day, the health insurance companies will cover some of the work, but on the whole, I would say that, a lot of the time they don't cover what we do. So patients have to be prepared to pay for it.
But I think it's quite short-sighted, because a stitch in time now will prevent a hip replacement later on, or a back surgery, or paying. Yeah. So I think you have to go, Simon, quite soon, don't you? You've got a busy clinic this afternoon.
Yes, I'm going to have to probably shoot off, actually. So I've got to go on and press on.
Yeah. Okay. And anything? So how can people find you, Simon? I mean, it's just Simon Holt, Costain, Harley Street. I mean, he can't miss you.
Well, we run a place called the Gait and Posture Centre.
Yes.
And we're at Flat 6 Harmont House in Harley Street. If you look up Gait and Posture, GAIT and Posture Centre in Harley Street, then you'll find us on the website.
Yeah.
And we'll be very happy to help people who want to come and see us.
Yes.
Always. So there's phone numbers there, which is the main phone number is 0207 636 4465.
Yes.
And you just look up Gait and Posture Centre on the web. You'll see us there.
Yeah, very easy to find. And so, and when's the? Have you been out in the boat now since the lockdown's finished?
I have, yes. I've been sailing, and we're looking forward to doing a bit more sailing soon.
Yeah.
But it's as you probably know, a lot of sailing stopped during the lockdown. But we're starting to open up a bit more now, which is nice.
Yeah, that'd be good. Great time. Well, thank you very much for your time. And I'm sure it's sort of generated quite a lot of questions and things, and hopefully give people the insight. And again, I say, as with any colleagues, I mean, we don't bite. We're all quite happy to share our knowledge and experience.
Very much so. Very happy, and I'm happy to have any podiatrists into the practice who want to come and sit and look at what we do. Of course, as you know.
Yeah, and I do here in Ireland as well, even though I don't practice.
Yeah, good.
They can come and shadow one of my colleagues, especially because we really specialize in the manual foot mobilization therapy.
Yeah, you do.
Yeah. Great. So Simon, thank you very much.
Well, it's lovely to chat.
And to chat to you. Just give me a minute. I'll finish this and we can have a quick catch up. So bye everybody. I think that's it for the last live for this week. It's only Tuesday though. Oh, I'll be live tomorrow morning, my usual business chat at 7 a.m. With Celia and with Kate and with Dave James. So until then, we'll see you then. All the best. And we'll end the broadcast.